Welcome to the deep dive. Today we're getting into polycythemia. It's a really key area for your MSRA revision, so we want to make this super clear for you.
Absolutely. Think of this as your central guide.
Uh-huh.
We're looking at what happens when your body makes too many red blood cells. That's polycythemia in a nutshell.
Too many red cells. Okay, but I guess it's like more complicated than just that. There are different kinds.
Oh, definitely. We mainly split it into two main buckets. You've got primary polycythemia. That's where the issue starts, right in the bone marrow.
You're right.
And then there's secondary polycythemia, which is triggered by something else going on in the body.
Okay, so primary, the factory itself has a glitch. Secondary, the factory is just responding to signals from outside. Makes sense. So our mission today is to give you that clear, sort of memorable overview for the MSRA, covering everything, definition, causes, complications, maybe some memory tips too.
Exactly. And understanding this isn't just for the exam, is it? It's fundamental for good patient care down the line.
Yeah.
So let's kick off with the basics. The definition. What exactly is polycythemia?
Right. So definition-wise, it's that excessive increase in red blood cells circulating. And that means you get higher levels of hemoglobin, the protein carrying oxygen, and hematocrit, which is the proportion of blood volume that's red cells.
Precisely. And like we said, you've got the primary type, Polycythemia vera, PV for short, bone marrow issue.
And the secondary type caused by those external factors stimulating production. But you mentioned something else earlier, relative polycythemia.
Ah, yes. Good point. Relative polycythemia. So imagine the number of red cells stays the same, but the liquid part of your blood, the plasma, goes down.
Okay.
So the concentration of red cells looks higher. Dehydration is a classic cause. Or there's Geisbach syndrome, sometimes linked to stress, maybe smoking too.
Ah, I see. So the numbers look high, but it's actually less fluid, not truly more cells. Like less water in the squash makes it look stronger.
That's a great way to put it.
Yeah.
So the blood count looks high, but it's a concentration thing.
So how do we tell the difference between this relative kind and, well, true polycythemia?
That's where we need red cell mass studies. This test actually measures the total volume of red cells in the body, not just the concentration. And if that volume is over, say, 35 milliliters per kilogram in males or over 32 milliliters per kilogram in females, then we're talking true polycythemia, a genuine excess of red cells.
Got it. That's the key measurement then. Now, I saw a note about uterine fibroids causing heavy periods leading to clinical polycythemia. That seems a bit unusual.
It does, yeah. It's less common, but basically the chronic heavy blood loss can, over time, sort of stimulate erythropoietin production. That's the hormone telling the marrow to make red cells.
Right.
And eventually this can lead to a picture that looks like polycythemia. Just shows how interconnected things are.
Huh. Fascinating link. Okay, so we've got the definition, the types, primary, secondary, relative. Let's dig into the why, the etiology. What causes these?
Right. For primary polycythemia vera, the absolute key thing, the name you need to remember for MSRA, is a mutation in the JAK2 gene.
JAK2.
Think of JAK2 like a switch controlling red cell growth. In PV, this switch gets stuck on, so the bone marrow just keeps churning out red cells uncontrollably, even when the body doesn't need them.
JAK2 stuck on like a faulty thermostat cranking up the heat. Okay. What about the triggers for secondary polycythemia?
Okay, secondary. Here, the main driver is often hypoxia, low oxygen levels in the tissues.
Hypoxia.
Yeah, so think chronic lung disease like COPD or living at high altitude where there's just less oxygen in the air. The body senses this lack of oxygen.
And tries to compensate by making more oxygen carriers, more red cells. Makes sense.
Exactly. What else? Well, certain tumors can actually produce excess erythropoietin, that EPO hormone we mentioned.
Tumors making EPO.
Yeah, renal cell carcinoma kidney cancer is a classic example. So a problem in the kidney leads to too many red blood cells. It's a really important connection to know.
Wow, okay. Kidney cancer link. Noted. Any other big triggers for secondary?
Smoking is a big one. The carbon monoxide in smoke messes with how well red cells carry oxygen, effectively creating a state of hypoxia.
Right.
So body, again, tries to compensate.
Right.
And then you've got certain medications. Testosterone therapy can do it. And EPO itself, obviously, think about athletes doping or sometimes inappropriate medical use.
Okay, so low oxygen states, weird hormone signals from tumors, smoking effects, certain drugs. That covers quite a range. And just to recap, the big categories: relative fluid issue, primary bone marrow JAK2 issue, secondary triggered by something else.
Perfect summary. And for secondary causes, maybe a little mnemonic helps. Think HLT.
H12A, okay.
H for hypoxia, COPD, altitude. A for abnormal EPO production, like those tumors. L for lung disease generally. And T for testosterone or EPO use, HLT.
Hypoxia, abnormal EPO, lung disease, testosterone EPO. That's actually really helpful. Okay, so we know the causes. Who's more likely to get this? What are the risk factors?
Well, family history can play a role, suggesting some genetic link, though PV itself isn't usually directly inherited in a simple way. Age is a big factor. It tends to affect older adults more.
Older adult.
Yeah, typically over 60 for PV. And there's a slight tendency for it to be a bit more common in men than women.
Okay. Older age, slightly more common in males, maybe some family background. And I guess exposure to those triggers we just talked about, smoking, lung disease, those meds, that increases risk too.
Exactly right. It's often a mix of maybe some underlying predisposition and those environmental or medical exposures.
Right. So we know what it is, why it happens, who might get it. How does it actually work in the body, the pathophysiology?
Okay, so for primary PV, it all comes back to that JAK2 mutation. It basically makes the bone marrow cells hypersensitive to growth signals.
Hypersensitive.
Yeah, so you get overproduction of red cells mainly, but often white cells and platelets too. The big consequence is that rise in red cells, the high hematocrit and hemoglobin. This makes the blood much thicker, more viscous.
Bigger blood.
Yeah, think of it like trying to push treacle through pipes instead of water. It just doesn't flow as well.
Yeah.
And that causes a lot of the symptoms and complications.
Right. Sluggish blood flow because it's too crowded with cells.
Yeah.
And for secondary polycythemia, what's the mechanism there?
Secondary is more of a logical response, even if it's excessive. The body is either sensing low oxygen, that's the hypoxia pathway, or it's being stimulated by too much erythropoietin.
Okay.
So the bone marrow gets the signal, make more red cells. It's doing what it's told, basically, responding to that external stimulus. The trigger is different from the primary marrow problem in PV, even if the result, too many red cells, looks similar initially.
Okay, so primary, the factory's faulty. Secondary, the factory's responding, maybe over-responding to an external signal. Got it. Now, if we see someone with high red cell counts, what else should be on our minds? The differential diagnosis.
Yeah, super important for MSRA. You see, erythrocytosis, that general term for high red cells, you need to think broadly. First, rule out or identify those secondary causes. Is it lungs? Is it kidneys? Is it smoking? Got to find the root cause if it's secondary.
Right, finding the underlying why for secondary is key. What else mimics it?
Definitely relative polycythemia, the dehydration one we talked about. Always check hydration status. Is the patient actually volume depleted? That's crucial.
Check for dehydration. Good point. Anything else?
Then there are the familial erythrocytosis. These are rare inherited conditions causing high red cells, but they're genetically different from PV. They don't have that JAK2 mutation.
Okay, inherited types, but not JAK2.
Right.
Right. Let's talk numbers. How common is this stuff, especially in the UK?
Overall figures aren't really tracked centrally, but for polycythemia vera, we know it's quite rare. The incidence new cases per year is estimated somewhere between maybe 0.1 and 2.6 per 100,000 people.
Wow, okay. So really not common. Maybe just a couple of cases per 100,000 per year, and mostly in older people.
That's right. PV usually diagnosed over 60, and that slight male predominance we mentioned.
Okay. Rarish older adults, slight male bias for PV. What about secondary? How common is that?
Well, secondary is much more variable.
Sure.
Its prevalence really just mirrors how common its underlying causes are. So in places with high smoking rates or lots of COPD, you'll naturally see more secondary polycythemia.
Right. It just follows the pattern of its triggers. Okay. So what might actually make us suspect polycythemia in a patient? What are the clinical features we look for?
There are some classic clues. Think about symptoms from that thick blood. Headaches are common, dizziness, and weirdly fatigue. Even though there are more red cells, the sluggish flow can make people tired.
Headaches, dizziness, fatigue.
Okay. And then there's pruritus itching, especially after a hot bath or shower. That's quite characteristic, particularly for PV. And you might notice the patient looks quite red-faced, a sort of ruddy complexion.
Itching after a hot bath, ruddy face. Super good flags. Anything else we might find?
Yeah, you might feel an enlarged splenomegaly because it's working harder dealing with all the extra cells. Blurred vision can happen from changes in blood flow to the eyes. And crucially, the risk of clots goes way up. Things like DVT, PE, stroke.
Those clots sound like the really serious part, and sometimes people might not have any symptoms at all.
Absolutely. Quite often, especially early on, it's completely asymptomatic. It just gets picked up by chance on a routine blood test done for something totally different.
An incidental finding. Okay, so we suspect it maybe from symptoms or a blood test. What investigations do we order? What's the workup?
First step, almost always, is the full blood count, your FBC. That's going to show the high red cell count, the high hemoglobin, the high hematocrit. That's your starting point.
FBC first. What's the key test if we're thinking primary, thinking PV?
That's the JAK2 mutation analysis. If that comes back positive, it points very strongly towards polycythemia vera.
JT2 for PV. Makes sense. What about checking for secondary causes?
Well, if you suspect hypoxia, maybe they have lung disease or live at altitude, an arterial blood gas, an ABG, is really useful.
ABG for oxygen levels. Okay.
And measuring the serum erythropoietin, the EPO level, is also key. If EPO is high, it suggests something outside the bone marrow is driving red cell production, pushing towards the secondary cause. If it's low or normal in the face of high red cells, that leans more towards primary PV, where the marrow is overproducing regardless of EPO.
Ah, okay. High EPO suggests secondary, low normal EPO suggests primary. Got it. Any other tests sometimes needed?
Sometimes, yeah. A bone marrow biopsy might be needed to clinch the diagnosis, especially if the picture isn't totally clear, and to look at the overall health of the marrow.
Right.
In imaging, maybe an ultrasound or CT scan can be important to look for underlying causes of secondary polycythemia, like those kidney tumors or checking the spleen size.
Right, so a stepwise approach. FBC, then JAK2, a BG, EPO, and maybe biopsy or imaging, depending on the clues. So once we have a diagnosis, how do we manage it here in the UK? What are the goals?
The main goals are pretty clear. Number one, reduce that risk of blood clots, the thrombotic events. And number two, control any symptoms the patient has, like the itching or headaches.
Reduce clots, control symptoms. How do we do that?
Therapeutic phlebotomy is really a mainstay of treatment. That just means regularly taking off a unit of blood, like a blood donation. This directly lowers the red cell count and makes the blood less viscous.
Regular blood removal, okay. Simple but effective. What else?
Low-dose aspirin is usually given too. It helps make the platelets less sticky, adding another layer of protection against clots.
Phlebotomy plus aspirin. Are there specific drugs to lower the cell count?
Yes, particularly for higher-risk PV patients. Medications like hydroxyurea, or sometimes interferon, can be used to suppress the bone marrow's production of blood cells.
Hydroxyurea, okay.
And absolutely crucial is regular monitoring, frequent blood tests to keep track of the counts. And these patients are almost always managed under a hematology specialist for that ongoing care and adjustment of treatment.
Specialist care and regular checks are vital. What about the long term? What's the prognosis like for someone with polycythemia?
It really varies. It depends heavily on the type, primary versus secondary. Secondary often gets much better if you can treat the underlying cause, stop smoking, manage the lung disease.
Right.
It also depends on whether they develop complications, especially those clots. That's a major factor in outlook. And, of course, how well they respond to the treatment they're given.
So quite variable, but generally, can people live reasonably well with it if it's managed properly?
Often, yes. With good management, regular follow-up, the prognosis can be quite favorable, especially, as I said, if an underlying secondary cause is sorted. But it usually means lifelong monitoring and treatment, particularly for PV. It's a chronic condition.
Lifelong management usually needed.
Yeah.
Okay, we've mentioned them, but let's really hammer home the potential dangers. What are the major complications?
The biggest one, the one we worry about most, is that significantly increased risk of thrombotic events, DVTs, pulmonary embolisms, strokes, even heart attacks. That thick, sluggish blood is just much more prone to clotting.
Clots. Got it. Any other major risks?
Well, related to that is the general increased risk of cardiovascular events like heart failure, just due to the extra strain on the system. And specifically for primary polycythemia vera, over many years, there's a risk it can transform into myelofibrosis.
Myelofibrosis.
Yeah, where the bone marrow essentially gets scarred and can't produce blood cells properly anymore. That's a serious progression. Or sometimes, though less commonly, it can progress to acute leukemia.
Wow. Okay, so clots are the main immediate danger, plus other heart issues, and then long-term risks like myelofibrosis or even leukemia and PV.
Exactly. Which really underlines why getting the diagnosis right and managing it consistently is so important. It's about preventing those life-threatening issues.
Okay, that's a huge amount covered. So the key takeaway for everyone revising for the MSRA: polycythemia means too many red blood cells. Remember, primary, the bone marrow's own fault, think JIK2 mutation, and secondary triggered by something else, like hypoxia or EPO. HAT might help you remember those triggers.
Yeah, JAK2 for PV, HALT for secondary. And remember, the main management is usually phlebotomy and aspirin to cut that clot risk.
Spot on. Now, a final thought for you to chew on during your revision. Given how many different things can cause secondary polycythemia, what seemingly unrelated symptom, maybe something quite subtle, might make you pause and think, maybe I should check this person's FBC.
It's a great question. It really encourages that broad thinking, doesn't it? Looking beyond the obvious presentation.
Definitely something to consider. And listen, for more top-notch MSRA revision resources, honestly, you should check out pastthemsSRA.com. And there's also freemissSRA.com for loads of free questions and guides.
Absolutely invaluable resources for preparing. Definitely check them out.
Brilliant. Well, thanks for diving deep into polycythemia with us today. We really hope that's helped clarify things for your revision. Join us next time for another deep dive.